Hey, and welcome back to the 30-inch step. I'm Brian Griffith, Gunnery Sergeant, United States Marine Corps, retired. Today, I've got something special here. I've got Ashley with us, and she is an APRN and a CNP. So, if you want to introduce yourself and tell us a little bit about that.
Sure. So again, as Brian said, my name is Ashley, and I am, as he said, an APRN, which stands for Advanced Practice Registered Nurse. CNP stands for Certified Nurse Practitioner. Those two terms are relatively interchangeable. Other types of folks can be APRN, such as nurse anesthetist, nurse midwives. So that's sort of the blanket term. My specific sort of specialty under that is as a certified nurse practitioner. And my connection to Brian is actually through my husband. They were longtime school buddies from way back in the day. But my husband is also a Coast Guard veteran. He kind of took a little bit of a different route to join the Coast Guard and went through a program after some related career work in law enforcement and joined the Coast Guard in his 30s, served actually as part of Joint Border Patrol down at the New Mexico border, and some miscellaneous other deployments throughout.
So, you guys have been married pretty much the whole time
Yes.
that.
Yeah, we were married. Yeah, actually, before he enlisted, we had a 3-year-old at the time that he enlisted, and it isn't abbreviated. It's called their Depot program through the Coast Guard. I believe they're the only branch that does this. And so he went off to 3-week basic training. That's because he had done an extensive federal law enforcement training years prior. So he was able to do this abbreviated program and then got into his specialty area within the Coast Guard. And so he's done one of the things that the Coast Guard does, if we have any listeners, right, is of course their motto is always ready. So they do a lot of things like hurricane deployments, various other things like that. So while we have shorter deployments and they're typically stateside, they're also often with 2 days notice.
Rivers.
So
you're talking like rivers,
river flooding,
lakes,
any hurricanes. He did a couple of shorter deployments down along the Gulf Coast for a couple of miscellaneous hurricanes over the past 10 years or so there, and then they did do a joined in with Border Patrol during sort of our uptick of Border Patrol efforts.
Right on, yeah.
In the kind of southwestern United States.
My son actually cut grass for a coastie down in Texas, and he was doing Border Patrol stuff.
Yeah. So basically, if it's for protecting our borders, our waterways, that's what the Coast Guard does. And so that's been his specialty area, both before, during, and after that time. He's also been law enforcement, so federal law enforcement. And then now here locally in one of our smaller city suburbs, I would say small, a suburb, larger suburb, I guess, that we have here in Cincinnati. And so that's, kind of really why I have any business talking to veterans and military folks.
So as far as post-traumatic stress disorder and how you would fit into the realm as a CNP, tell us a little bit about your office, what you guys do, and then maybe come into what kinds of therapies your office does that might another office, that another veteran might be looking for.
Sure, absolutely. And so when we look at PTSD, post-traumatic stress disorder, of course, that covers a whole range of experiences and diagnoses. So kudos to the VA. They're really the first ones that truly recognize this post-Vietnam era, post-World War II-ish into Vietnam era, really recognizing that this was a thing, that this was a diagnosed disorder. And so a lot of the efforts initially for PTSD were within the military and veteran community. We have expanded this over the past probably 30 to 40 years to also include lots of other traumas. So keeping in mind that when folks enlist, or even when they are enlisted, but also, live a life outside of the military, their traumas may or may not be military related or often compounded. And so when we're looking at PTSD treatment, we have to look at all of that in mind. And for me as a clinician, to never make assumptions about what the trauma is. So sometimes I may think, oh, you're a veteran, combat trauma, great. No, it was because they perhaps were abused as a child. Maybe their military service was pretty uneventful. So we have to look at the whole range of traumas. So what a nurse practitioner would do within that scope is our primary sort of two-pronged approach is full assessment, diagnosis, so we're making sure they meet true diagnostic criteria, that you're getting the right diagnosis and that you're not out there either self-diagnosing, TikTok diagnosing, peer diagnosing, that we're meeting that official diagnostic criteria. And then our sort of primary specialty area is with medication management. We absolutely do therapeutic things, is how I often talk about. We have therapeutic conversations, but we're not therapists. That's going to be coming under a number of different credentials, usually a LPCC or licensed professional clinical counselor, licensed professional counselor, clinical social worker. Different states do have slightly different letters that they will use to kind of differentiate a therapist per se. It could also be a clinical psychologist. And so what a nurse practitioner does is really focus primarily on the med side of things, but there is definitely a lot of crossover there.
So what are some of the medications that you specifically, and I know, of course, with HIPAA
Sure.
and all that, like I'm not asking for any specifics on any particular patients or anything like that, but what typically would you look at? So, like for myself, of course, I take a Zoloft or Sertraline, but I've also been prescribed Trazodone, and that for me was a whole thing, and it actually scared me to a point that I didn't want to go back to them because I felt like they were just trying to medicate me, vice actually listening to me. And I think a lot of veterans have that kind of problem. So, how can we as veterans kind of open ourselves to the possibility of actual clinical psychology as opposed to here's this med and we're just a number?
Sure, absolutely. And I think the first key is to work with clinicians that are trauma informed, and specifically as it relates to veteran related trauma. And again, that might be trauma from different sources, but that there are clinicians that are trained and experienced and understand the military and veteran lifestyle. For myself, right, I won't pretend that I know what it's like to enlist and go through basic and be deployed, but I've been, the support person for that, and so I certainly have some, I guess, indirect experience there. So a little shout out to my office that we brought up earlier here in the Cincinnati area. I work for an office called Pinpoint Behavioral Health. And we are really, our sole focus are military veterans, first responders, some other helping professions, certain healthcare providers, folks like that, and their families, because we certainly know that it affects everyone in different ways. And certainly even what's going on with a family member is going to affect our service member as well, too. And so our focus, our passion is with this group of folks, and all of our clinicians have some degree of direct connection to the military or first responder family or community, or often both in my case. And so not only do we have some lived experience, but have gone through a variety of different trainings, continuing ed, et cetera, so we can begin to understand. A good clinician doesn't say, wow, I know what it's like. I really, I get how you're feeling. They might say, I understand that might be hard for you. So we can empathize and certainly appreciate the feelings without saying, oh, yeah, I totally know what that's like. I've been through that. That's not a clinician that really truly gets it. So when we talk about medications, first line of medications are actually our antidepressants, or our SSRIs, or selective serotonin reuptake inhibitors. And they have a bit of a mixed reputation out in the world. As Brian mentioned, he's on sertraline. That's actually one of our first line for PTSD. And the reason why, certainly there can be a element of depression that comes with it, absolutely an element of mood dysregulation. When we think about trauma, it changes the way our brain functions. And so we are always, when you've experienced trauma, that could be actual trauma, it could be the threat of trauma, often both at the same time, our brain starts to respond into fight or flight mode. That's what has been healthy in the midst of trauma. That's what causes our folks in the military to respond appropriately. The problem is when you get out and you're not in a dangerous situation, but your brain has not changed the way that it interprets threat, essentially, then we respond with really maladaptive coping mechanisms, our acute anxiety, panic, flashback, nightmares, avoidance, difficulty in relationships and interpersonal relations. So all of those symptoms are diagnostic criteria for PTSD. And so what is happening at the chemical level is really um, a change in the way that our nerve cells start to talk to each other. We send these little chemicals called neurotransmitters from nerve cell to nerve cell. And when that pattern gets off as a result of chronic cortisol release or one of our adrenaline, essentially, and often other neurotransmitters, dopamine can play a role, serotonin can play a role. When that process gets off, we have to regulate it again.
Well, the cortisol definitely
Right? Yeah.
kicks in for
Absolutely. And
for
like
us
acute
veterans after.
cortisol,
Yeah.
response is healthy and necessary. That's what, when you're lying in bed at night and you hear, a noise downstairs, you go into cortisol response. That's safe and healthy. When you're chilling on the couch, and you get a cortisol response, that's not what our body is supposed to be doing.
Right.
Our body has somehow gotten triggered in some way, and it often can be really subtle. It's a word, it's a sound, it's a smell. You may not even be able to openly identify it, but our body now goes into fight or flight. And now we're responding in ways that aren't good. So when we regulate those neurotransmitters, we get an improved response.
And I feel like for myself, right? I could smell something and have a panic attack.
Yeah.
And the anxiety is just, sometimes it's unbearable. Like leaving I went to a baseball game on Saturday at Great American Ballpark, and me and my son, we got in the truck, and of course we knew that there was going to be traffic leaving the parking garage, but then all the traffic isn't moving, and I start getting spun up, and I'm really trying to stay calm. I'm talking to my son, like, because a few times he was like, "Are you okay?" And I was like, "Yeah, this is just really hard for me." And I've started opening up a little bit more to the kids as they've gotten older, just so they understand, hey, Dad's not doing okay right now. But looking at it from their perspective of, I'm Dad, so I think I've started to get to the point where I can kind of understand my own, where a lot of other guys can't. And so as far as the med side of it, what are some of the, I hate to say side effects or symptoms or even effects that can happen on sertraline or I'm trying to think of some of the other meds.
Right, sure.
Please.
I could probably name them all out. Our classic SSRIs are going to be Zoloft, or sertraline is the generic name. Fluoxetine, which is Prozac, that's the OG of the SSRIs. We have Paxil, Celexa, which is citalopram, Lexapro, escitalopram. I get them all. Luvox, which is fluvoxamine. I think I got them all. I might have missed one. But anyway, there's a group of them. There's a lot of variants of those. You mentioned trazodone earlier, not technically an SSRI, is an antidepressant, although more often used for sleep these days than anything else. With our SSRIs, as well as our SNRIs, that's our serotonin norepinephrine reuptake inhibitors, those are meds that are covering two different neurotransmitters instead of one. So that's the basic explanation behind that. Any med that touches serotonin can do a fantastic job of regulating your mood. Serotonin is probably one of your biggest culprits with mood dysregulation, anxiety response. But we have serotonin receptors from head to toe, including some areas that make us feel good when we are with our partners, which means that any med that touches serotonin is likely to cause a decreased libido. And that is one of the top reasons that people stop taking their meds and they don't tell their providers.
Well, and then stacking on top of, so you get a lot of guys with ED, erectile dysfunction, things like that, and sometimes it is caused by the meds, and now they're taking this med, but then they're like, "Well, hey doc, I'm having trouble in the bedroom. What can I take for that?" And so for me, like, do I want to be on meds? No. And so, of course, I always think about exercise and diet, and the nutrition side of it, of course, is going to help tremendously.
All those things work. We just don't want to do them.
No,
and
exactly.
they're hard. And
Hey,
sometimes you don't have the motivation.
I like my
or the
ice
capacity
cream.
to
I
do
like
them.
my
Yeah.
steak. I
Yeah.
like food.
Right. Well, and the way I look at it, right, is the right med for you is the med that works for you and has either no side effects or whatever side effects you have are tolerable or maybe even desired. Like you're having trouble sleeping and there's a med that has a side effect of drowsiness, that's advantageous. We have meds that cause weight gain as a side effect. That's not great for some folks. For my folks that aren't eating and they're underweight, that's exactly what I want to have happen to them so they can level out. And so you work with your clinician to say, hey, this med's causing this side effect, or what I often like to do in my patients on the front end is say, hey, what are the types of features of medications that you are concerned about, or maybe are a hard no? If somebody tells me, I don't want a med that's going to affect my sex drive, I don't want to take any chances. And I say, okay, fine. We're not going to do that family. Let's talk about a different family of meds. They may say, I am absolutely, without a doubt, I will not take a med that has even the slightest bit of weight gain. Okay, then let's look at a different family of medications. Other people don't care, and we open some things up there. And so really you want to work collaboratively with your clinician and to mention about meds to treat other meds, right? Well, sometimes that is appropriate. We really want to avoid that as much as possible. And that also means being careful about getting disjointed care. And so whenever possible to try to get your care either under one roof if you're able, or with providers are absolutely going to collaborate with other providers and look at the big picture. So if we've got a med that's, taking away all your sex drive, and then we give you a med to help with ED, and then we give you another med to help with some other side effect, now we've got what we call, as clinicians, polypharmacy, way too many medications. And did you know that when you're taking at least 4 medications simultaneously, your risk of interactions is 100%, just statistically. Now, those interactions may not always be problematic, but you will be having them. And so, right, we want to keep your med burn as low as possible. That at the same time, making sure that your symptoms are treated. So I have patients all the time who are like, I don't want to take meds. And I'm like, dude, you're suffering. Why would you let yourself suffer when I have something that's going to help?
Well, and for some patients, right, they're on a type 2 diabetes medication like a metformin or some sort of blood pressure medicine, and then add in mental health medication, and they've had a heart attack and now they're on blood thinners, and you add all these things together, it's a petri dish. I feel like
it is absolutely, and we as clinicians have to look at that big picture and zoom out and kind of say, hey, what's the cost of this? The cost of it might absolutely be improved quality of life, but the cost of it may also be interactions. Now, fun fact here, we know research has shown what perhaps maybe makes the most sense logistically is that when we treat the mental health issue, we get significantly improved medical outcomes. I could tell you over and over again, the number of patients that I've had come in with PTSD, we treat their PTSD and their blood sugar starts to stabilize, right? Comes back to that cortisol response, right? Their blood pressure gets better. They're exercising again because they actually have energy and motivation to do it. So it's not all bad, right? We may have to kind of, sacrifice a little bit to get a far better outcome before too long.
Well, and for myself, when I was in Texas and actually getting therapy, I went through EMDR, and just the relaxation of sitting there, and of course we had to start with the trauma, right?
Starts with the hard stuff, yeah.
Always had to start with the trauma, and it was always like, do I really want to do this today? And there were some weeks where I was going multiple times a week, and so I would go in there and end up just talking to her. Hey, what things have come up in the last few days, whatever. But then she recommended the medication and said it's okay to take this. And she knew the docs on base, and so I was able to get the medication, and it helped me sleep better. It helped my mood. It helped my relationships. Plus, I was on a CPAP too, so It's amazing what happens when you're actually sleeping.
Right. Do you know how many
Um,
people I beg to please wear their CPAP? They will feel better. It's a
please wear your
daily
CPAP.
conversation in my clinic.
Please wear your CPAP. If you get issued one of those things, just use it.
I know it's not the
Um,
sexiest thing out there, but
well, and they've got the what is that Inspire
the Inspire
now
device,
that
yeah.
you can have installed.
Mhm.
And I know a couple of guys that have that, and they seem to like it, or at least they don't notice it. So, but for myself, right, going back to the EMDR, um, especially after my first like kind of breakthrough, um, I asked her. I mean, it took me like an hour and a half to almost leave her parking lot after this because I was just a mess. But I found myself to be able to like kind of get through it, right? And start to notice that, hey, I'm gonna be all right, right? And I walked into it, and I think I put it down here in my notes, but I leaned on my faith, and I kind of want to bring that into it a little bit, just to kind of what what things can a veteran expect, right? If they were to come to your office, right, and you guys in process them, what kind of things could they expect from it or get out of the therapy? How can the meds help with that, depending on their.
Yeah.
And
Yeah.
then what about like, do you guys refer them out for like procedures like the ganglion block or
Sure.
things
Yeah.
like that?
Yeah, absolutely. And I can speak for our office in saying passionately, you are not a number for our office. And I know so often in the military you are. That's the
Well,
that's
and
kind
that's
of
the VA's
exactly.
kind of thing, right?
And so in our office, I mean, you come in, we're gonna call you by the name you want to be called by, however you choose to. You're going to come into a warm, welcoming setting because we also treat first responders, of which, of course, there's almost probably a disproportionate number of veterans in that career field as well. So you're going to get people, even in the waiting room, that are like you on some level, that have had some similarities. And at least in our office, like I said, everyone that works for us has some connection to the military veteran or first responder community. So
So it's
somebody that's going to,
personal to you.
yes, it's personal. And a lot of folks, myself included, and several other folks in our office, have do work outside of the office with nonprofits that help veterans and first responders, and really feel extremely passionate about this population. And so when you come in, it kind of depends on which clinician you got scheduled with first, which is often just schedule availability. Did you see a therapist first, or myself? I'm the only nurse practitioner in that office. We're going to do a full assessment. Yes, we're going to talk about trauma. We are trained, though, not to just be like, hey, tell me what kind of trauma you had. And really, we go through clinical training to, use the right kind of words and the right kind of demeanor. One of our pet peeves out in the world, and this is why we're really passionate about working with particularly military trauma informed clinicians. And I'm sure you guys have all been there when you're talking to your civilian friends and they say, "Oh my God, what was the worst thing you saw in war?" Right? Absolutely not. Absolutely not. That's not cocktail party conversation. You want to talk about that with your buddies, you get it, right? And so you don't want to sit with a clinician going, "Oh my God, what was your worst trauma?" Right? This is not a gossip fest. I'm very particular about what I call kind of clinical voyeurism, where a clinician is essentially trying to listen for the interesting stuff. Right? I'm listening for clinical criteria. I'm not listening for you. I've met some extremely interesting people in my career, but I'm there to treat them, not to hear their story. If I want to hear their story, I'll read their book or whatnot. But it's not about making you relive the trauma. You do that enough. We want to understand the nature of the trauma, and in certain situations like EMDR, where an EMDR trained clinician is going to get into really the meat of that trauma. For somebody like myself, I'll often say, "Tell me as much as you're comfortable with." It helps me to understand the general nature of it, mostly so I can understand how to help you. It may be something as simple as are you somebody that doesn't do handshakes? Are you somebody that wants a male clinician or a female clinician, as best as we can accommodate that? That's not always perfect. Is this, one of the things I actually had to get used to in working with this population is the idea of deference. And so we're often trained to do what we call patient-centered care, where I might say to somebody, hey, I've got, here are a couple of ideas. Sertraline might help, but also Lexapro might help. Here's some pros and cons. What do you think? And one of my transitions as a clinician with the military and first responder community is they often said, whatever you think is best. And I say, well, I have some degree of expertise. I like to think I know some things in this area, but you're the expert in how you feel and what's important to you. And so we really need to work together. So don't be afraid to advocate for yourself. I'm not your commander. You don't have to defer to me. We need to work together on this.
Well, and I think a lot of us, because we're not doctors, we're not clinicians, we don't know. And a lot of times, especially with the VA, they're ready for the next person. They're ready for the next person. So a lot of times when we go in there, I've been lucky. I've got a primary care doctor that she was like, what did you leave the Marine Corps taking? And so I told her what medications I had, and she was like, okay, that's fine. We'll keep you on those, but let's get you in with they had told me I had a Barrett's esophagus, and they started giving me pantoprazole. And when I went in with her, she was like, how does that work for you? And I was like, I don't know. I don't notice anything. And she was like, okay, let's get you in with gastro and see where they go with it. And I get in with them, and the guy was like, you might not actually have a Barrett's esophagus. They weren't totally diagnosing those correctly. You might have things that may lead to that, but you probably don't actually have it, because Barrett's esophagus, for anybody who has that, talk to your doctors, and try to get them to tell you what's going on with that. But for mine, it was, they told me, we're going to keep you on the pantoprazole, but the next time we do the scope, whatever, we're gonna see what it actually looks like and do a better diagnostic on what's going on. So, yeah, talking to your doctor, that's
advocate for yourself.
Yeah,
because that may not have been the culture you have been in, and depending on how long you've been out or what your unit was like, you may not have been in a situation where you felt like you could advocate for yourself. One of the things that makes mental health a little bit unique is that our diagnoses sometimes are fluid. I often describe it kind of like a big giant Venn diagram. And so, for example, with PTSD, we're going to have some, sort of standard anxiety. We're going to have mood dysregulation. Well, that also happens in major depressive disorder. That also happens in ADHD. So then my job is to kind of fleece that out. But one of the differences is, with medication, we're treating symptoms. We're treating symptoms in the context of that diagnosis. But I'm not going to wait until I get the absolute most precise diagnosis, send you for testing, do all this, and then, 3 months later, we're like, okay, it's this exact thing. Let's start an antidepressant. Guess what? You have to wait 8 weeks for it to kick in. So
that was going to be my next
that's
question.
the cruel irony about these medications. Yeah. There are as needed medications that you can take for acute symptoms, primarily anxiety symptoms, sometimes sleep. Some are controlled substances. Those have their place, but they need to be used very judiciously.
But it's like a build-up?
Yeah. Well, yeah, you can grow a tolerance. They have abuse potential, depending on your role, if you're still active duty or if you're first responder. Sometimes there's some work implications with those types of medications, but there are non-controlled, even non-sedating options for acute anxiety flare-ups. So what I would say kind of a general formula that I often like to do is start an antidepressant, start an as-needed medication, come 2 to 3 months down the road, that as needed is back on the shelf. You're good to go, but we gave you both immediate and longer term relief. And then, of course, with that, therapy, right? So like I said, I'm not a therapist, but I'm going to work very closely with our therapist. In my office, I have the liberty of literally walking next door. Sometimes, it's a matter of getting on the phone, but a good clinician of either, credential is going to collaborate with your other clinician, maybe your primary care provider too, depending, and kind of say, hey, what are you seeing? This is what I'm seeing. This is what we're working on.
How are they able to notice I say notice like differences in that person
Mhm.
on the meds as opposed to all like they
Yes.
haven't been taking it, right?
Usually, a really good therapist, especially one if you've built a good rapport with them, they know. They often know before I do because they're probably seeing you more often. My job, amongst many hats, is to be a detective. So, a disadvantage we have in psychiatry is we have very few lab tests that will show a blood level. There's a couple meds that do, but most of them not. So, one like, say, a bacterial infection, we give you an antibiotic, symptoms are gone. If we wanted to, we could probably draw a lab and double check. But in psychiatry, it's not really that clear. And we also know that the way that the body metabolizes these medications can vary widely with folks. We're learning more and more about that almost by the day. And so there's a lot of variance in that. We want to know, certainly I'll ask a patient, but I'm also looking for those other symptoms and signs. Sometimes loved ones, I'll get panicked calls from loved ones. Sometimes they come to the appointment. I would say, we talk a little bit in this population about battle buddies, but also turn to your spouse, your adult children, whoever maybe is also your sort of accountability partner in a day to day, maybe in your house or close to you, to be able to kind of support you in that. And, did you take your meds? Not in a patronizing way, but just did you take your meds? If not, what's making it a problem? One of the other challenges in choosing the right medication is even working with one's schedule. So if you're out of the military, you're working a civilian job, and you've got a 9 to 5, that's pretty easy to find a med that works within your schedule. You're working, 12-hour nights, and I'm giving you a med that makes you sleepy. Well, then we need to talk about when is the most appropriate time to take it. It may be appropriate, but at a different time that I might take my med that makes me sleepy.
Yeah.
And so we have to look at that and see what are those other factors. If it's a med that requires 2 to 3 time a day dosing, we have a great anti-anxiety med, non-addictive maintenance medication out there called buspirone that can be really helpful, but it requires 2 to 3 times a day dosing. Every single time we add a dose during the day, we reduce compliance. So, what's the likelihood? I'm not going to remember, and I get paid to talk about this all day long. So, I can sure as heck, bet that most of my patients don't remember. So, we're going to problem solve proactively. If I say to somebody, I've got this, Matt, you got to take it 3 times a day, and they're like, I'm not going to remember that, then
So
we're not going to do it. We're going to find something else.
the clinician that actually helped me with the sertraline told me that it might make me drowsy.
Mm.
It's a 24-hour thing, so I only
Yeah.
have to take it once a day. But before I brush my teeth in the evening, I take that,
Yep.
and then I don't feel like I notice anything, but the long term, I think I noticed that it helps me be a little bit calmer in certain situations. It helps me notice when things are kind of building up in inside myself. So in those ways it is nice to have the clinician actually talk to me and tell me, because I wasn't getting that on active duty.
Yeah.
So again, going back to what you were saying of talk to the clinician, advocate for yourself. And I started asking questions, and she was like, well, when do you take it? And I was like, usually in the morning with the rest of my medication. And of course I take supplements and stuff like that too, but she was like, well, what do you take in the evening? And of course I take like a magnesium and that kind of stuff. So she was like, just take it with that stuff and then go to bed. It'll help you sleep.
Yep.
So
Yeah, and that's a great example of like a side effect that actually might be advantageous too. It's
yeah,
not all
right.
bad
No,
stuff, but
yeah,
but we have to know how to use the medication,
sure.
and and whether somebody's lifestyle is going to be work with this medication regimen. And if it's not, it's my job to find something else that does. It's not my job to say to you, "We'll figure it out."
How
And that is often, unfortunately, the modality in a lot of areas of medicine. But we really have to work together to find something that works.
how often do again, I think they started me on sertraline and then took me off. This was while I was on active duty. They ramped me up. They started me at like a low dose. It was like half a pill, and then they ramped me up, and then I was like, do I really need this? And the doctor, psychiatrist or whatever was like, oh, well, that's really up to you. And I was like, all right, I'm just going to go ahead and stop it. Now, should I have? No. Uh, I'm glad that I'm still on it now, and I went back on it. But during that during that transition period where I was getting ready to retire, I should have been taking it, and I wasn't. And I finally talked to them, and the the psychiatrist at that time said, "I'm going to go ahead and give you enough to last you into your retirement." I think they ended up giving me a 6 month supply, just so I could get into the VA system. And once I got in with them, I mean, it's been 3 years now, but they're they ask me every year, how do you feel? Do you feel like it's still doing what it needs to? And so I feel like, again, I feel like I've had a pretty lucky go at.
Yeah, I mean, you actually are statistically pretty lucky for finding the first med that works.
Yeah.
It's pretty common that we're finding, you know, 1, 2, 3 trials or more. We have protocols as clinicians of what to do if we're not going to keep just trying more of the same. Sertraline didn't work, so let's try fluoxetine. So then let's try citalopram. We're not going to keep doing more of the same. So we do have kind of stepwise approaches to look at some different maybe types of antidepressants, mood stabilizers, which kind of segues into what I'm going to talk about here in a second. But yeah, I mean, what you don't want to do with antidepressants is go on and off. We've all been there. I'm not always compliant with my medication. I'll be the first one to say it. And we usually pay the price. Sometimes it can take a while, but we're going to realize that maybe we needed it. It does not necessarily mean you need meds for life. I cannot make that guarantee on anyone. You know, whether it be through therapy, through other treatments, you may be able to come off or lower your med burden. And so it's really, a lot of times people ask me, am I going to take this for the rest of my life? And I give them the extremely precise answer of, I have no idea. But we are going to get you to a better place. And when we get you, the kind of the general rule of thumb is we get you to a stable place, keep you there for at least a year, then we can start having those discussions about coming off. And it's doable. I take people off meds all the time. I just did today, actually. But on the other hand, sometimes we don't want to mess with a good thing too.
Sure.
So to kind of segue, I wanted to answer your question from a few minutes ago too about other procedures. And so again, this is what happens. Sometimes if meds aren't effective, maybe we can't use meds for one reason or another. And so there are a couple of other treatments and lots of cool stuff going on in the lab too. So I've been in this business over 20 years, and some of the things that we do now, we thought were just totally wackadoodle 20 years ago. So one of the things that you can consider is something called pharmacogenomic testing. It's not the end all and be all. Some of you may have heard of it. There's a couple of different companies that offer this. This is testing that you can, we do a little DNA sample. It's a little tickle in each cheek, just a tiny little saliva sample. And through that sample, the lab that does this is able to kind of break down some of your enzymes and therefore give a kind of prediction of how you might metabolize a number of different medications. And so it really can help us kind of narrow the playing field. I describe it a lot like a GPS, and we certainly have been getting from point A to point B since the beginning of time without our GPS, but it does make it more precise. It does not take any other factors, like that's a terrible intersection, or, I don't like to cross that light takes too long, or whatever. All those other factors that influence our drive, right? Same with genetic or pharmacogenomic testing is, that doesn't take into account that we don't like that dosing regimen or it's brand name and still expensive. But it's a great option. And, fun fact, Medicare
And I was just about to
and
ask
TRICARE
that.
cover it in full, and many states Medicaid does too.
So and for some veterans, right? They're using Champ VA.
I believe that does too, because that typically falls under
I think it's like a
Medicare rules, basically. So
Gotcha.
yeah, so
Okay.
ask a provider. You do want to approach that kind of test with a degree of caution. Some people will ask me for the test. It tells them what meds to take. I'm like, well, it's not really quite that simple. It's not going to give you a report that says, Brian, your med is sertraline. Don't even entertain anything else. It's going to say, hey, these meds, your body is more likely to metabolize better, thereby implying a better response. But again, it's not the end all and be all. But it's often a helpful tool if we're like, God, they're just not responding the way that we would thought they were. Maybe there's something going on genetically that impacts how they respond to medications, and we can often get a little bit more precision.
Are
that
you
way.
able to send your prescriptions to the VA?
Yes. Yes.
Because
So yeah,
especially
civilian.
for a lot of the guys that would
Yeah,
guys and gals
civilian
that be watching.
prescribers can do that. Now the one challenge, it's not a huge challenge, but those prescriptions and even the patient has to be in the state where the clinician is licensed. So I'm like only licensed in Ohio. I can't send your med. I mean, usually if it's like an antidepressant, nobody really worries too much. But I can't, go see a vet in Oregon and send it out to the VA there.
So
That's
like
not okay.
being in a tri-state area like this,
Mhm.
so Ohio, Kentucky, Indiana,
Mhm.
um, do you guys? I mean, we're pretty farther into Ohio here, but do you are you able to, let's say, if you had a patient that lived in West Harrison in Indiana and they were coming to you, would you be able to prescribe that medication to them,
Yes.
but they would have to pick it up here?
Yeah,
Or
yeah.
okay.
So, and again, non-controlled medications usually aren't the biggest deal, but really recommended that they or that the patient is literally located in the state where I'm licensed, which means you can live in Indiana. If you cross the border and come to my office, if you, it's a little weird, but we got to do what we got to do. You just have to be in Ohio. If you want to do telehealth and you drove your car and sat in the gas station,
Hey, I'm gonna
you can
pick
do
up my
that too.
meds at
Right.
Walgreens in
Yeah.
Harrison. Sure.
Exactly. Makes it feels kind of weird, but it can be done. Really one of the cool things about telemedicine these days is for years and years we were always told meet the patient where they are, and that was more of a concept. Well, now we get to do that.
Well, I
So
bet a COVID
yeah.
probably
Yeah,
thrust you guys
COVID
into
really,
that. Yeah.
it really is, sped that up. Mental health had been doing telemedicine for a little while before that. Actually, the VA was instrumental in getting that started.
Now, as far as statistics, do you
Mhm.
see? I mean, results. When
Yeah.
you look at the metrics of it, do you see um like an uptick in I would rather do telehealth?
Yes, absolutely. Absolutely. And, not only is it convenient if you particularly live way far out, if you are working and, if you can take 20 minutes during your break time and talk to me for a med follow up, or take 3 hours off to drive to my office, meet with me, wait in the waiting room, and leave, like, what are you going to do? Right. So we want to be able to, truly meet a patient where they're at. I take many calls from break rooms, from cars. I'm like, hey, if we can make it work, let's do that.
Well, and
Yeah.
living closer to Cincinnati and working
Yeah.
closer to Dayton for me,
Right. Like that's a
like
3 hour.
my
Yeah.
VA office is out in Claremont County, and so when I do have appointments, it's like,
Right.
uh, hey, if you guys can do this over the phone, I'll just do it in the parking lot at
Exactly.
work.
I know it feels kind of weird, but this
Sometimes.
is life in a post-COVID world, so we're we
Right.
are doing things virtual.
Right.
There's something really special about that face-to-face, but I also appreciate if you have trauma, if you have childcare issues, if you are really anxious about this, and it would be a lot more comfortable to sit on your own couch and start to build rapport. By all means, let's do that. Let's not delay care. We know depression's a great example. One of the prime symptoms of depression is just this complete sort of apathy and lethargy. I can't even leave my house. We maybe have all been there. And so then are they going to come in for an appointment to get help for the thing that, is keeping them? Probably not.
Right.
But if can they log on? Like they may be able to do that, and then we can kind of meet them halfway. And that makes such a huge difference.
Yeah. So the next two questions really, I feel like they kind of flow together.
Mhm.
So for me, like what worked for me, hey, I did EMDR, and it was more God centric. I actually went to the first appointment and told the lady, unless Jesus is at the center of this, I don't want anything to do with it. And so I know that's not going to work for everybody. Of course, faith is always something I feel like people should have. But I know sometimes there's church hurt, there's that kind of stuff, right? And so, finding what's right for you. But then there's also the stigma of getting help, right? And coming from someone who had a clearance, who has a clearance, um, there was always that, well, if you say this, you may lose your clearance, or if you're in this kind of job, you might not be able to stay in that job. Um, so especially for you being in the community for the last 20 years, um, what kind of changes have you seen over the years that have either made things better, and of course we talked about doing the telehealth and that kind of stuff, but um, what are the differences that you've seen over the years that have improved and made things better overall, and then how can that help our watchers, our listeners, to kind of understand, like, how am I going to fit something into my schedule?
Yep, absolutely. And I will say that, in my opinion, the number one reason people don't get treatment for their mental health symptoms are their mental health symptoms, right? The very nature of those
Oh,
symptoms
I have
make
to
us right, right.
actually confront this?
Yes, yes,
Yeah.
right, exactly. And we look at, say, things,
Oh,
something
yeah.
like depression. Well, okay, so our negative thinking goes, well, nothing's going to help. No one can help me. No one even, we get into those negative thought loops. So why on earth would you try to get help? Because everything in your brain's
Well,
saying it
and
won't
now
work. Yeah.
exacerbate it by, I was in the United States Marine Corps.
Yeah, exactly.
Marines
So, yeah,
Marines are go hard or go home,
right.
and yeah, there's nothing wrong with me. But
Absolutely.
then
So
but then the negative thoughts kind of start
yeah,
creeping in, and again, like, over the last 3 years since I retired, there have been 10 Marines that I've known in some form or fashion that have taken their own life. And why?
yeah, absolutely. There is
They had
help.
families,
Yeah,
they had loved ones that were there for them, and then those loved ones are left,
yeah,
like, what could I have done
right.
for
Absolutely.
them?
There is always help. It can get better, and I know that well, I wouldn't even say it can. It will get better, and I know that feels kind of trite. I'm not saying it's going to be an easy road, but it will get better. I've, like I said, I've been in this business for 20 years. I know, which is weird because I'm only like 25, right? I think,
Yeah,
but
no, for real.
not old enough for that. But I've yet to find somebody that's not treatable. Are there people that resist treatment? Yes. Are there people that are kind of going against maybe what would have worked? Yes. But everyone's treatable. It does get better. And we had talked, kind of glazed upon this earlier. There are other treatments besides medication. So there is a treatment called the stellate ganglion block that's been a game changer for trauma. There's things like transcranial magnetic stimulation that's been a game changer for trauma. So it's meds, it's therapy, it's a support system. That's our three-pronged, stool. I often tell people, like, guess what? I have the answer. It's really, there's three: meds, therapy, and a support system. And even under the med umbrella, I would even expand that to be other treatments too. But kind of point is medical treatment, therapy, support system. One of those legs may help be heavier than
Well,
another, but that's your answer.
and the
Right?
support system for some, right? They feel like they don't have anybody, and that's
Yeah.
where this show and why the 30-inch step is so important, is it's something that every single person who has worn the uniform, or the cloth of our nation, can say, during recruit training, they taught me how to march, and we marched together. And we forget, after leaving service, that, hey, I should reach out to my buddy, because maybe he was having the same kind of thoughts, and we can do this together, right? We can take the 30-inch step together. And that's one of the hardest things, I think, for all of us, because there's so much, pride, and it it
And really, I mean, Brian, it even, we go a generation or two back from our parents, certainly their parents. We weren't talking about this. I talk about this a lot when I'm getting family history. They're like, well, I don't know, because
hey, here's this beer,
right,
shove it
exactly,
down and shut up.
right. And we didn't talk about it, or maybe it was minimized, or maybe we're like, oh yeah, we had like one crazy aunt, but nobody ever talks about her, or whatever.
Right,
Those sorts of things, and
right.
so kind of creates a stigma unintentionally. I often say, well, sometimes give your
No,
parents a
don't
break.
bring
They
that
didn't
up.
know, but
Don't bring that up with
yeah,
grandpa.
exactly. And so there was likely a family history, but we probably didn't know, and so it's there, and we put all those pieces together, genetics, situation that we're in, and this is how we are. And so we it can be hard sometimes. Maybe they have great battle buddies. Maybe their spouse is super supportive, but their dad is telling them, "You're not going to take some of those, crazy pills, are you?" Right? And then now what happened? Right? So,
Well, Dad thinks negatively of me
right,
for trying to take care
exactly.
of myself.
Exactly. And
Yeah,
so, yeah, so, that support system all around, and to talk about it as it makes sense. And I'm so glad you brought up what your kids know. I mean, certainly it's got to be age appropriate, but normalizing these diagnoses, just as we do when we're physically ill, when we need to go to the hospital, when mom has a baby, right? We're talking about all those things very normally. And then we don't want our kids to know about our mental health struggles. That actually inadvertently can create a stigma with them without any poor intention on our part. And so I'm so glad it's okay to talk about it with your kids. Certainly, choose your words and your situation carefully.
sure.
But, like great example with your son, like he knows enough to say, okay, I got this. If he need, I don't know if you're with the one that drives or not, but if he needed to drive home that day or if he needed to take over,
Right.
great. I mean, awesome. And so, your support system can look in different ways, and it doesn't always have to be in relation to your illness. I talk a lot about kind of, particularly like our friend group. There's the one friend that always makes you laugh. You wouldn't tell them a serious thing a day in your life, but you hurt when you learn them because you're laughing so hard. There's the friend that's always serious. There's the friend that's always going to be, picking you up from the airport at midnight and, fixing your lawnmower and doing those sorts of things. Sometimes those are all the same people. But it doesn't all have to be somebody that you're going to sit down and bare your
Sure.
soul to.
Sure.
It might just be, a good group of good people in you and they don't always have to be military and vets. In fact, occasionally I'll run into a vet or a first responder who's like, well, I don't want to reach out to those folks, sometimes because of assumptions. And
Right.
they're going to think I'm
Right.
crazy or they're going to one up me with their trauma. Sometimes that happens too. And so you have to kind of think about what is that really that diverse support system that's going to work for me.
Well, and for myself, moving back to Ohio, your husband and the group of friends that I had growing up, we meet once a month, and it kind of sucks me out of the thoughts of military. I know some of them hear me talk about that kind of stuff because it is very endearing to me, that I served and that that was a big part of my life. But I also like that I can sit down with your husband and just BS about just
Right.
life in general,
Right.
and him inviting me to that movie on Friday. It was great.
That's normal
I
people stuff, right?
well,
Like that's
right.
not,
It's
right?
normal things,
Yeah.
right? And so I can extract myself and be like, I'm just one of the guys. And I think a lot of veterans a lot of times have a hard time being one of the guys again. And like if I got asked to go back in the Marine Corps, yeah, because I know what to expect. I know what I'm doing. I'm broken to the hilt, but I'll make it work.
Right.
Um,
Isn't that
but
sort of the weird irony? Because you think of like all this stuff that you've been through, and you spent all this time working on trauma. Hell yeah, I'd go back into it, right? For us civilians, sometimes we look at them and be like, "Are you nuts? Like, who would do that?" But
I posted
the military
something
guys get
today.
it, and
I
girls.
posted something today. I don't know if you saw it, but it was like the top 10 things that veterans think about a lot of times or have a hard time with. And, one of them is just that. Like, I miss the suck,
Right.
right? Like,
Right.
it sucked while I was doing it. It sucked while I was wearing it, but damn, do I miss it.
Right. Because, really, there's no greater brotherhood and sisterhood, right? Than, being in the depths, being challenged emotionally. And I won't try to pretend this is a comparison, but I talk about this sometimes with my nursing friends and some of the bonding experiences we've had that we can't go tell our non-nursing friends about because that's totally messed up.
Well, and
But,
some
we have
things
a
that you've
bond.
seen.
And-
Some
yeah.
things that you've seen.
Yeah.
And it's like that has to be traumatic as well.
Yeah.
So,
And it's a
yeah.
great, vicarious trauma is real, and that's the trauma that we get from sort of being the secondary person. As clinicians, we're very vulnerable to vicarious trauma all day long. I mean, just the other day, I had an extremely intense day of just patient after patient with just horrible stuff. I mean, usually it's interspersed with some routine things, but it was just a really heavy day. And, that's vicarious trauma. Like, I have to take care of myself if I expect to take care of you folks. Our spouses that either hear the things that you tell them or just innately know, right? A good spouse, you don't need to tell, but they've already experienced it. And, that's all vicarious trauma. And that's actually one of the reasons why we treat families too at our practice, and why good practices should, because it's multifaceted. And
Well,
I
if you get
often
the
joke with
family
my
involved,
husband
yeah.
when he was deployed. He's going to get mad if I say this, but he was deployed to the border. He got to stay in a hotel for a couple months. I was single parenting it with a 3-year-old, no, a 5-year-old, I think, and a 1-year-old, by myself working full time. So who should have gotten the DD 214? Right?
I
Exactly.
I
Yeah.
won't say that I don't agree with you. Um,
I'm
and,
not
and
saying he didn't work hard.
no,
I'm just saying I worked hard
and,
too.
and that's the thing, right? My wife and I are coming up on 19 years married, and I mean, most of that time I was in uniform,
Yeah.
and so it's just as much hers as it is mine.
Yep.
Although my name was actually signed on the dotted line, because we were married, she had to go where I went, and unless it was a deployment. And so, all 4 of my kids were born in different places. And so,
And that's hard for spouses to uproot and go wherever.
right,
Yes, the military does have a support system, but that's still meeting new people, finding new friends, getting adjusted with kids. Spouse is often working, and
right,
so it's not easy. Sometimes in countries where there's a language barrier, I mean, that's very challenging on a spouse. You do it together, but that doesn't mean it's
right.
easy.
Well,
Yeah.
and I think I've our family has been so blessed by God for being able to have her stay home and homeschool the kids. And we, if one day we're like, hey, we want to travel, we can turn that vacation into a study, into, hey, we're going to this place, we want you to figure out all the cool places to go to, and how much does it cost, all that kind of stuff. And it's a research for them, but involving them in that kind of stuff, and it helps us to kind of take the load off of us, and give them a little bit of that, and it teaches them that, hey, I can do this too, and it gives them a little bit more strength,
Absolutely.
and you know moral fortitude
Yeah.
to
When I think when we talk about
cope.
getting help, like people love to tell us, all the time, right? Like what can we do to help? I remember the last deployment my husband had. Again, it was a hurricane. Actually, I
Yeah.
think it was a COVID level deployment, and it was 48 hours. You got to be in Detroit. And all my friends, what can we do to help? Well, we also know when that happens, some of those people mean it with all their heart, and some of those folks just say it because
Oh,
it feels good.
please
Right.
don't ask me.
Right,
Please don't ask me.
exactly. I have
Yeah.
learned, and my sister, who also is the wife of a veteran, he's now deceased, we've learned together that to specifically tell them what you want or need.
Yeah.
You don't have to be worried about it, but you can just be like, what I really need is for you to pick up, my kid from school. And one of the things, one of my big pet peeves is actually they always want to come over and take your kids. I'm like, all I want to do on the couch is sit on the couch and snuggle with my kids. But I can't because I got laundry. I got to work full time. I got to,
Yep.
take care of the dog. I got to do this. And so they
There's
always want to take your kids away. So I often have found that if it's more of a like, here's the task I need. Would you mind setting up a meal train? Would you mind picking up my groceries?
Hey,
Can you find somebody who can mow my lawn?
Venmo
That's
me
help.
Venmo
Yeah.
me some money, and I'll get your groceries for you.
Right, exactly. So think about
Right.
what you want and need. And and if it's more of a mental health issue, right? We always talk about, right, nobody brings casseroles after a suicide, right? And we need to start talking about that because in a little side note, suicide is what happens because mental illness can be fatal. and it is the end of a fatal illness. And if we look at it with that line, or as we know somebody is suffering and struggling, we start to change our mindset and say, this isn't just a personal failure. We say, this person was really very, very sick, just like somebody who may be sick with some other cancer or another serious illness. So we do need to support the individual and family. That might be food, that might be presents, that might be, some freshly baked cookies you left on their front porch and ran away.
Yeah.
It might be a note. I felt like we were all pretty good about this in COVID because it was kind of fun and novel for a little bit, and then it fell apart. But those sometimes what we need is presence. You don't always have to have the right words. I remember I learned this very early in my career as a nursing student, being put in with some situations in the psychiatric setting were just awful traumas. And I remember going to the nurse that was training me and being like, why did you have me meet with that person? Like, I don't know what to say. I don't know what to do. I'm like 20 years old. How do I deal with this? And the answer is, you don't have to know the words to say. You'd have to be real and genuine and present. And so that's true whether you got, some letters after your name like me, or whether you're, 3 months into your initial enlistment. Just be real and present.
Right.
That's all you need to do.
So with the last couple of minutes that we've got here, I kind of want to go into like resources,
Yeah.
I know that you guys have a website. I know that there are Ohio websites, some national websites. And I'm going to put most of these up on the description for this particular podcast, but things like Mighty Oaks, and I know that's very faith-based, and
it is. It's a faith-based, peer-led group for veterans with PTSD and their families, I believe, as appropriate. They have different retreats.
I think I saw on their website that they have things for families.
They do some really good work. I actually brought a list. You can keep this.
Yeah, absolutely.
A couple of the ones I talked about. There's a program called Save a Warrior or SAW, and they offer. It's a 3-day kind of peer support-led retreat. So it's not therapy. I don't believe there's any clinicians there. It's kind of peer support, which has great value. We actually have seen the great value of that, both in the military and first responder communities. And so there's that program. There's also a program called BRAVE, and it stands for an acronym that I don't remember, but it's out of the University of Wisconsin. Both BRAVE and SAW are free. You have to apply to them, and you have to figure out how to get there. But they do offer a free. The BRAVE program is with clinicians, but treatment for PTSD as well as traumatic brain injury, which, of course, unfortunately, with our veterans frequently goes
usually
hand in
if
hand.
they've got a traumatic brain injury, they've got post-traumatic stress.
Absolutely. And there's a couple of other facilities. Well, there's probably lots of them, but I'm going to list the ones I know. A place called Chateau Recovery. They're out in Utah. Absolutely gorgeous surroundings. Sierra Tucson in Arizona, of course. There's some places in California. There's and really through the Wounded Warrior Project, there's a number of different resources, something called Project Odyssey, and some other support resources through there. There at Mighty Oaks, we mentioned. Even big shout out to one of my favorite military vet charities is the Gary Sinise Foundation. They do some really cool stuff for vets, including some mental health wellness supports with some retreats. Also some fun stuff. My sister, whose husband was a 20-year Louisiana National Guard vet, passed away a number of years ago. And the Gary Sinise Foundation took them to Disney World this past year, gave them VIP treatment. So
Tunnels to Towers.
Tunnels to Towers is a great one.
Yeah.
This is even probably just the tip of the iceberg. So there are tons of resources out there. Did want to actually share an interesting resource a lot of people don't know called the STAR Behavioral Health Program, or STAR Providers. And that is a program out of Uniformed Services University. And I think they did some partnership with Purdue as well. But it's a training program for people like myself, for civilian behavioral health providers, to get training. And it's a multi-level training, days long, a whole bit, to help us understand military culture within the military and largely post-deployment, of course. That's because that's when we're seeing them. And it's taught partly by veterans who've been involved in the veteran mental health community. And so we get it. I mean, again, I won't try to pretend I know what it's like, but it wasn't like a 1-hour continuing thing. This was a multi-day training, and they actually have continued trainings after you get your kind of
you've been in the game long enough now that you've seen the veterans and understand.
Certainly, life experience helps with that too.
Sure.
And you can, if you're looking for basically a veteran or military informed provider, you can just go to starproviders.org, put in your zip code, your insurance, the whole bit. And your local clinicians will come up, and that's nationwide. I'm not sure if it's at all 50 states, but a large number of them. I think they're working on all 50 states.
Well, and
So you can get a civilian provider that has done some education.
so you talk about peer kind of
Mhm.
stuff, right? So for myself, Centerpoint Christian Church up here in I I don't know if it's Westchester or Liberty
Yeah,
Township.
somewhere on that
I don't know
gray
the
area
line,
there.
but
Yeah.
I started a group at that church for veterans and even active duty. I mean, Wright-Patterson Air Force Base isn't too far from here. And so I started this group with the not even expectation, but with the thought of what about us,
Yeah.
and making it more, again, God centric, and just being there, being that sounding board for someone that may need help,
Yeah.
may need a clinician to actually help them.
Yeah.
So doing this particular show was in the hopes to do exactly that.
I mean, and we know, I mean, we've seen that the research, certainly through common sense, that peer support is invaluable. We have actually a pretty extensive network here in the Cincinnati area, and I'm sure other cities as well, too, for peer support within our first responder community. And I know the Wounded Warrior Project also has some peer support approaches in a variety of different ways through there. One of the things, a shout out to my husband, because he did this both in the city of Cincinnati, which is somebody else's project, and then in Hamilton County here in the rest of the area, actually a program through our law enforcement where if law enforcement happens to learn of a veteran in any kind of crisis, it might be mental health, it might be they can't pay their rent, it might be any kind of thing. They're going to send a law enforcement officer who is a veteran out to meet with that person.
And what's really nice is your husband actually added me to the list.
Did he? Yeah,
for,
it's so
for
cool.
any Marines out there
Yeah.
in the local area here.
Yeah. And it's really become a cool program because now, since that, my husband's met some really cool guys. He met this 100-year-old World War II veteran. He got a new roof for some guy through one of our local roofing companies that gives free roofs to veterans. I mean, we've met some really cool people. And he, occasionally I'll go have a beer with a Marine he met a while back who was in a mental health crisis. And so, really just to be able to say, hey, I'm one of you, right? They actually, there's pins that they can wear. And I know that's a program out of the state of Ohio, but I suspect other states probably have something along those lines too.
And that brings me right back to the
Yeah.
30-inch step.
Yep.
Us leaning on each other,
Yep.
and finding ways that are going to help us. Yes, the VA is there. If you need help, immediately go to a VA.
Yep.
Yeah, they may end up having to check you in, but at least you're somewhere safe. And again, the group at my church, we're there to help get somebody to the help they may need. And so, in closing out this show, and I really appreciate you sitting down with me today.
Absolutely.
If you're in crisis, there are many options for you. If you're immediately needing something, dial 988. Text
There is a
988.
There's a specific veteran option when you call
Yeah.
them. So
No, I saw that
yeah.
on their website, and I think it's incredible that there are so many programs out there for us, and most of them we don't know about.
Yeah.
And I feel like a lot of times it comes down to shows like this to actually sit there and call out those programs that are available that may not even need insurance.
Yeah.
And
a lot of them, are free. You might have to apply to them, or you might have to figure out how to get to
sure,
the program.
I mean, Military One Source is
Yeah.
an option for the active duty
Yeah.
and reserve side of things, but Military One Source is available for veterans up to I think it's up to 1 year after they leave service. So there are options out there, and there are a few that you have brought up that I knew nothing about until you actually put it in my lap. So when anybody who's watching this video, make sure to go into the description and check it out. There will be links in there for you. Please reach out, leave a comment. Even if you're in crisis and you need something, hit up my email address for this show. It's the dot 30 dot inch dot step at gmail.com. Yeah, I had
Did you
to
get all the dots
I had
in
to
between
really,
that?
it
Yeah.
was so bad. And the number 30, not the word 30. And give me your address. I check my email a couple of times a day. So if I see something, I might be able to call the police department close to you and have them come out and check on you. Um
And really, I know we talked about stigma earlier and people worrying about their career, their clearances. And I'm going to say something very frank and a little harsh, but those things don't matter if you're dead.
100%.
You know,
100%.
your life is far more important than any of those things. Once you're alive, once you stay alive, we can build everything back up from there.
Right.
But if
Right.
that's the reason that you're going to not get help and make it get worse, don't.
Right. Well, I really appreciate you sitting down with us.
Absolutely.
I expect to see some really good numbers from this one. So with that, thanks for tuning in to the 30-inch step, and we'll see you next time.